Good morning. We all know that we are entering an era of precision medicine in last decade, and you can see through this timeline of events where initially we were subtyping it as small cell versus non-small cell. Later, after all these molecular advents, now in 2024 we have plethora of things to understand and subtype. We all know that lung cancer mortality is decreasing and survival are increasing due to multiple factors. One of the factors is subtyping a disease properly and understanding its biology. So delivering targeted therapy to biomarker patients, as we can see whether they are oncogenic drivers versus non-oncogenic drivers, when the driver targeted therapies have resulted in better survivals. Now, how NGS is directly impacting the survival, we can go through the further slides where we can delineate each subtype where we have a better survivals compared to traditional chemotherapy regimens. So in this slide you can see in FLORA trial, however, osimertinib has improved median overall survival to 38.6 when compared to conventional chemotherapy, which is 8 to 10 months alone. And we all know in profile trial where crizotinib has improved along with entrectinib to 50 months and odd. So all these oncogenic drivers are a bit costly, but still they are definitely worthy improving survivals of patients with less toxicities or specified toxicities rather than complicated toxicities which we see with traditional chemotherapies. So we have a lot of things to identify coming from PD-L1, EGFR, ALK, ROS, BRAF, NTRK, RET, MET, HER2, and MET amplification, now KRAS, and other immuno-oncology biomarkers. We have to identify tumor mutation burden, inflammation, a lot of things. The problem is there is more complexity in testing, standardization, and understanding the reports, and we have to identify a clinical need and patient wishes and what is the accessibility to these drugs, whether they are available in India or we have to import access, or what is the knowledge and awareness and how much experience we have to deal with these drugs and their related toxicities and reimbursement issues. And there are plethora of NGS platforms available in the country which creates much more confusion. So coming to CAP or IASLC or AMP guidelines, we have a lot of guidelines which says that the treatment patterns are different when the patient has expression of PD-L1. The whole treatment pattern is different in stage 4 NSCLC where PD-L1 more than 50% versus PD-L1 less than 50% in diagnosis and decision making and survival patterns and counseling. Everything relies on this stratification. So even in squamous cell carcinoma, PD-L1 IHC testing is a routine, and we also know that 3 to 5% of squamous cell carcinomas are oncogenic driven. So we have ESMO guidelines where it mandates that testing is required because every stratification is based on whether patient is having this specified mutation or not. So primarily we subtype as small cell versus non-small cell, then squamous versus de facto adenocarcinoma, then PD-L1 IHC testing is a mandate. Then again, whether it is NGS platform or IHC platform, we test for EGFR, ALK, ROS, BRAF, NTRK, MET, RET, and HER2. Then determining on biology and these biomarker findings, we can divide them into oncogenic driven versus non-driven and tailor our therapies accordingly. So coming to WHO lung classification, and it is extensive depending on morphological type versus oncogenic type. So, and by using earlier methods of IHC, we could rarely subtype these NSCLC. Now we can better subtype NSCLC, and the rates of NSCLC and OS is less than 10%. So what it will provide, whether this biomarker testing is like, it will stratify the patient and indicates where the probable drugs can be used. And also it is also based on decision making of stage of the disease and performance status of the patient. So whether we should test every lung cancer sample for everything. So fixation and processing and handling and storage issues like initial biopsies, when we are going to process it after 2 years or 3 years, the quality of DNA and quality of nucleic acid in the sample is a very big problem. And sometimes the newer metastatic sites are not amenable for biopsy, or patient is not convinced about rebiopsies because it's invasive quite. So processing, fixing, and preserving samples is also an issue. So initially we are so simple, we can diagnose morphologically, then we are not bothered. But nowadays, with each recurrence, we should test again and again, and we should take decisions based on real-time monitoring of these tissue evolutions. So coming to dual track testing, when European Union, where they do biomarker testing parallelly with NGS-based testing on DNA or RNA extraction samples, where multiple mutations and fusion genes can be found parallelly along with morphological testings. So ideally we should test for everything if affordable and possible. Otherwise a few, like at least EGFR, ALK, ROS, PD-L1 is a must. So PD-L1 IHC testing is now a routine standard. So in SP263 assay, which states only 50 cells are required, but majorly we assess on basis of 100 accessible tumor cells. And the report is stratified as less than 1%, 1 to 49%, and greater than 50% to base clinical indications and also prognosticate the people. So again, as we discussed earlier, the tumor is present or not, how much the lab knows how to process it, whether nuclear percentage in the sample is adequate or not, and quality of RNA or DNA in the sample, and whether it is adequately tested in PCR methods by NGS or not. These needs to be identified and has to be matched with controls to understand the report comprehensively. So current diagnostic standards on which gene alteration should be tested for, we have standard EGFR exon 18 to 21, BRAF, KRAS, MET, HER2, and gene fusions like ALK, ROS, RET, and NTRK. So assay and sensitivity and specificity, we should know at least 20% of tumor content is needed to get an ideal report. So, and we also know once testing, it's not adequate. When patient progresses, again, we need to know why the progression has occurred. Sometimes in baseline samples, we can see the primary mechanisms of resistance, then we can prognosticate the patient to go for either clinical trials or other alternative therapies which are available at better places. When patient is acquiring a second resistance over the time of treatment, then we can know what are the interventions which can be done. Like if patient has transformed to small cell lung cancer when he is primarily adenocarcinoma, then chemotherapy is one of the options. So multiplex testing is certainly way to go, but the thing is cost and the reliability, standardization of the techniques and reports, how validate they are, and understanding detail about coverage of NGS, and also multiple IHC biomarkers with validations and parallel testings is an issue. So multiplex parallel testing of all required biomarkers is generally ideal, especially ALK, ROS, NTRK, RET fusions or EGFR, KRAS mutations are mainly tested. So reflex versus bespoke on demanding testing, generally reflex testing is preferred when patient is aware, and you have an MDT, generally that's the way in good centers, we have MDTs, molecular MDTs, and their reflex testing is automatically practiced, but in some centers in peripheries where you don't have many of the options or treatment accessibilities and availabilities, then we should go for bespoke testing. Then depending on triage of patient and condition, we can discuss in MDT and review the test. So if something is good and cheap, it can't be fast. If something is fast and good, it can't be cheap. So we need to understand all these things while counseling the patient, and informed choice making on discussion with the patient is the key. Because patient will be on so much hope when he's spending so much amount on this multiplex testing, he thinks some magic is going to happen to him depending on this result. Sometimes we don't get result on DNA sample, then we need to run it on an RNA sample, and again it's a time consuming process. So most of the turnaround time recommendations are different. In clinical practice, many NSCLC patients are not tested for all actionable biomarkers, even in best of the best countries. So evidence suggests that testing is frequently less than recommended guidelines. That is quite true in India and other South Asian countries. So mainly the communication is vital, whether it is on discussion with the patient or in the MDT, or your quite frequent interactions with the molecular lab to understand this testing and nuances and newer updates is must. Biomarker selected therapies definitely work. That's why we do have a lot of precision oncology clinics nowadays, and testing guidelines and multiple recommendations exist. We need to tailor according to your pattern of practice, and definitely recommendations get updated. We need to also get updated with that recommendations, and we need to uptake it in the community is also a must. Thank you.
Thank you very much for the talk.